Great. Thank you everybody for coming. Brian, thank you for organizing this. I remember last year, this is probably twice the number of people we had last year. This is really exciting how these things start. All big things start small, as Gandhi once said. I'm going to talk today about complications of tendon repair. My disclosures are I'm a speaker for MiMedx, and I'm also a consultant for Acelity. I don't think I'll be discussing any of those things except possibly a little bit about MiMedx. And talking about complications with tendon, I have to tell this, it's all about being specific, because a lot of the specific complications have to do with the specific tendon repair. So a man got two wishes from a genie. He wished for the best beer in the world and the best woman in the world. The genie snapped his fingers, and the man had a glass of the best beer made in the world, and he was sitting next to Mother Teresa. And that's, it's interesting because tendon repair are all different. The extensor tendon is different than the flexor tendon, which is different than tendons in the forearm. I'm going to talk about kind of general complications and then all specific, and of course the most famous tendon repair issue coming up. So tendon repairs is specifically flexor, specifically zone 2, famous for complications. Extensor tendon repair, famous for being called to the emergency room to diagnose. Why? Because people always say, I think there's an extensor tendon repair, but I don't know. Why? Because the patient can still extend their fingers. Arm tendon repair is famous for being a doctor called to the emergency room when the doctor is sounding very scared. Why? Because there's usually a lot of bleeding associated with it. And tendon repair complications. So adhesion formation, joint contracture, tendon rupture, pulley failure and bowstringing, infection, and hematoma. So I'm going to try to cover all of this in 20 minutes. Kind of really, I'm going to answer questions at the end, but kind of a general overview. So let's talk about this first. Flexor tendon repairs are known for causing trouble, as we all know. Zone 2 was called no man's land, and I looked it up and I said, why? Where did this start? And this is basically pictures of no man's land from World War I, and this is how surgeons before 1967 saw flexor tendon repair. Just wasn't done. They used to say you cannot do Zone 2 flexor tendon repairs primarily. They don't work. Obviously we do it all the time now, and we get great results, or I should say very good results. And where did this all start? Well, before 1967, Zone 2 repairs were not done. They were done secondarily. And in 1967, there was a paper done at the American Society of Surgery of the Hand, which was called Primary Repair of Flexor Tendon Injuries in No Man's Land by Kleiner. And what was interesting is that no one believed him. Everyone attacked him. They said, this will never work. You're out of your mind. They actually sent 3 guys to Kleiner to watch him do it because they thought he was a liar and they didn't believe him. And they saw his results and they said, okay, this is something we can do. And it's interesting. So now we do primary results in no man's land, but it's still one of the areas that have the highest complication rate. And why is this? Well, obviously the tendon sheath, blood supply, and adhesions. A lot of times you have to cut the blood supply or you interrupt the blood supply when you're doing the repair, and that's where all of our tight pulley system is. So what you want to do is reduce scarring, reduce adhesions, get stronger healing, and avoid rupture. So I did a review. I'd say, are there anything that we can do to prevent? Obviously the best way to get the best results is prevent issues and early repair. Right now, the patient usually comes to the emergency room, and if we can, we do it immediately. We try and do it in the next couple of days, but they've shown studies that even waiting 5 or 6 days may have a worse result. Early range of motion, the most important, suture technique, and they've shown that possibly doing a 6 or 8 strand suture technique will improve the result, and pulley preservation and repair. There's actually, I looked and I did a review on pulley preservation and repair, and I found no less than 8 different ways of doing a pulleyplasty. So outcome predictor. Looking at the outcome studies, what they found is they found a correlation between early repair, smoking, age, early hand OT, and technical aspects. The technical aspects are basically doing a 6 or 8 strand technique, doing a pulley release, pulley reconstruction, or venting. The tension across the repair, and short splint early hand occupational therapy. With the tension across the repair, what's interesting is they've found that if you bunch the tendons slightly, the patients have a slightly better result. And the problem with bunching the tendon slightly is you have to get it in and out of the pulleys. So if you do that, then you have to do a pulleyplasty in order to have the patient have a better excursion. The other thing that's interesting is one of the best results of any study that I've seen is one where they do the patient awake. I don't know if Brian or Roger do this or Lawrence do this now, but doing the awake repair where the patient actually does excursion in the operating room had the best result in terms of long-term. Just some future perspectives. They've done a study looking at no splinting. So basically, patient doesn't get a splint out of the operating room, patient just gets a dressing with ACE wrap, and they found that those patients do better. Obviously, some of these patients we can't trust. A lot of the patients who I see, if I used no splinting, they would drive home by themselves from the operating room. Growth factors and wraps. They're showing that using different wraps that contain growth factors or added growth factors during the time of the operation has an increased healing rate. Adhesion control factors. Again, these are similar to the wraps. These are things that go around the tendon during the repair. Custom suturing, stainless steel suturing devices, and then they have, instead of being growth factor wraps, these are tendon wraps that reduce scar formation that are usually basically periosteum, or they're using pericardium, or different kind of dermal replacements. Okay, so one of the major complications that could occur, which decreases your overall outcomes, is having an infection after the flexor tendon repair. Why? It causes increased scarring, it causes increased inflammation, the swelling makes it difficult to do the hand-occupational therapy. So the question is whether you use post-op antibiotics. Right now there's a clinical trial going on looking at post-operative antibiotics. It makes intuitive sense, but there's no clinical data. Sure. Next is hematoma. Hematoma also has been shown to have worse results with tendon repair, no matter where it is. Increases the chance of infection. Also has issues in terms of increased scarring, increased inflammation, difficulty in having hand occupational therapy. Next, pulley reconstruction. So when you're doing the repair, having pulley reconstruction actually is one of the few outcomes that they can judge in terms of. Okay. So, in terms of future perspectives, there's several different products out on the market that have been shown to reduce tendon adhesion. One is growth factor products. So basically these are mainly amnion, these are the ones that have been tested. And these are wraps that you put around the tendon. They've been shown to have better tendon healing, reduced rupture rate, decreased pain. But again, these are very, very small studies, haven't been shown to be useful in terms of large groups. Okay, so I'm just going to talk quickly about arm tendon repair, extensor tendon repair, and flexor tendon, not in zone 2. Rupture. Ruptures are a pretty rare complication, but studies have shown this could be up to about 5 to 10% depending on other things that are going on at the same time you do the repair. So if the patient has an infection, the patient has a hematoma, the patient has skin loss, all these things increase your chances of having a rupture. If it's a very simple, straightforward laceration to the tendon, the rupture rate is very, very low. If it's a complex kind of injury, the patient has been crushed, the patient has dirt in the wound, the rupture rate is very, very high. It's actually interesting, it's more common in the non-dominant hand. It's higher in leg repair, and it's higher with when the patient doesn't have a pulleyplasty. So this is a combination of two different injuries I'm going to show you. This is whenever you have a middle finger tendon laceration, this is always what you see. But this is a simple laceration. And this is also a patient who has a tendon laceration. The problem with doing these studies, by the way, this is a real patient that Brian and I took care of. You guys remember the Superstorm Sandy? She was going on Glen Cove Road, and her car turned over because the light was broken. Turned over, crushed her hand, and this is what came in the morning of Superstorm Sandy. The problem with doing tendon lacerations is this is qualified as a tendon laceration. The previous patient is qualified by a tendon laceration. So all tendon lacerations are not the same. This patient is going to have a bad result almost no matter what you do. And the other patient before this is going to have a good result no matter what you do. So just talking about infection, again, can be as high as 1 in 20, but it really has to do with what the injury looks like. Antibiotics. Most of the time we do empirical antibiotics. Again, it's a kind of a clinical choice. There's very little downside, but at the same time, if a patient has a complication, or sorry, if a patient has an infection, it's going to be an issue. Hematoma and skin necrosis. Again, involves meticulous technique. There's 2 different ways at the end of the case. Sometimes you take the tourniquet down after the patient has a dressing, other times before. There's been no study to show this, but people have recommended that if you take the tendon down before you close the wound, that you may have better hemostasis. Adequate debridement is very important to reduce infection rate, and sometimes late debridement is necessary. These are patients who have a crush injury, the skin is necrotic, and it actually becomes an issue in terms of having necrotic skin over your tendon repair. It's probably better to go back early, and they've shown that these patients who have an earlier skin graft do better. Quadriga effect and tendon shortening. This is a common muscle belly for the tendon. A lot of times when the tendon is cut, it's a frayed end. When you repair a frayed end with debridement, the tendon will be shorter. So you have a quadriga effect where that tendon which is repaired is tighter. Bowstringing. Bowstringing is where there's damage to the pulley at the same time you do the repair, and the pulley is not repaired. Patients obviously have decreased range of motion. And these are 2 different types of pulley repairs. One is using a alloderm type structure, and the other one is using the superficialis tendon. Both show excellent results. And future therapy. So what's interesting is they're looking at gene therapy for decreasing fibrosis. So basically you're able to insert a gene into cells that you put into the wound. These create collagenases at the same time you're doing the repair. So they're using this for scar prevention, fibrosis, and different fibrotic diseases. So you take cells from the patient, you can quickly do gene splicing and put those patients back in, so they're creating a natural low level of collagenases. Tendon replacements. So they actually have repaired tendon, different polyurethanes. So what they'll be able to do is, instead of taking a tendon graft, you'll be able to replace it with these incorporated polyurethanes, which have a biological structure on either side, and these won't get adhesions. Why? Because they're inert. Growth factors and wraps, which I talked about before, mainly at this point placental and amniotic products, and they both decrease fibrosis and increase healing. Custom wraps, like I said before, also are mainly barrier products and scarless healing. Scarless healing these are techniques where you use different steroids and different additional products to create a scarless healing milieu for the wound. Great, thank you.